Good afternoon, everybody, and you're very welcome to the Communications Roadshow. It's our first in-person roadshow in UHL since before the pandemic. We visited all the other sites, so today is our last event. My name is Elaine Conley. I'm the Communications Director for the group. So the format for today is we'll be inviting the CEO, Colette Cowan, to talk a little bit about the winter plan, and then just to give us a brief update on the patient flow on the Deloitte review. Noreen Spillane, then our Chief Operations Officer, will talk about unscheduled care improvement plan and waiting lists. And then Lorraine Rafter, the Director of HR, will talk about HR policies, updates and staff engagement. After that, we go to a Q&A, so you're very welcome to hold any questions until the end. We're also broadcasting virtually as well, so we have some staff joining us online. So I would just say to them that the Q&A option is open for that, to submit your questions from any time now. And then just for everybody who's in the room, there's a feedback card at the back of the room. It would be really great if you take some time at the end to fill that out so we can use your feedback to improve any future events. Thank you. I'll just hand over to the CEO.
Oh, there was only 3 people behind me when I came in. I didn't realise you all snuck in afterwards. But you're all very welcome. Thanks for taking the time to come to the CERC to hear this talk, and equally to the people online. I just want to mention that my Chief Financial Officer, Dave Frawley, is going to put his hand up here as well. Dave Frawley, yeah. And Chief Director of Nursing and Midwifery, Declan McNamara, who's also here with us today, and the Chief Clinical Director, Professor Brian Lennon. So the executive team, in effect, and you've just met the Director of Comms as well. So as Elaine said, today I'm going to talk 2 minutes on the winter plan, because the winter plan, the bespoke plan, only came down to us in the last week based on funding from government. And there was a number of items that we had pitched in the winter plan and in the operational plan and estimates for the hospital group, namely additional NCHDs for the emergency department. It's a busy area, it's busy in the evenings, and support from NCHDs is required there to see patients faster and get them on a treatment pathway faster as well. Additional radiographers also to support early discharge, increased discharge coordinators, and particularly in out of hours, and patient flow coordinators at weekends to assist ward teams in moving patients out of the hospital to other areas. The Older Persons Assessment Unit, I think we're calling it the GEM now, latest title, the Geriatric Emergency Medicine Unit, opened last week, I believe, with 5 beds, and there's 5 more beds to open in it. It'll take time, it requires some refurb work, and it's in the old MAU and overflow unit that existed near ED. And that work is really moving at a pace. It's an area we're interested in because it's for over 75s, and as you know, our biggest number of patients that come into hospital are over 75 and they're most vulnerable, and in the main most of them need admission and to be looked after. And there's really fabulous work with the Optimum team in ED, and it's expanding that work further in the health and social care professions and the input they make into older persons' lives, enabling them to get home and get treatment and care. And also then flu and COVID-19 vaccine campaigns will always be funded, of course, in the winter plan. So all of those areas that I've named out have been funded. We're just working through it at the moment to ensure that they're in place as quickly as possible to get us through the next few months. The flu, just a word on that, and the COVID-19 vaccine campaigns, I would urge you to make sure that you have your flu jab. It is really important, especially after the few years that we've just been through, and indeed your booster for COVID-19. COVID is around, the numbers are rising, you see that in the media as well, and I believe the flu isn't the very nicest one based on the southern hemisphere and what they've just come through in Australia, so it's not something you want to weaken your lungs on. So I would urge people to do it. I do know that people go off site for flu vaccine down to the vaccination centres, and we're reviewing that at the moment to see can we do any in-house, because I think it's easier for staff to be able to hop in a lift and get your vaccine here on site. If we can do that, we will. We're just working on that. So that was the winter plan. The monies are divvied out across the country, as you can imagine, but it doesn't take from the fact that we still will have high numbers of patients coming in to the ED this year. So let's talk about the patient flow review. Deloitte were commissioned in March 2022 to provide an independent and comprehensive overview of patient flow in ED at UHL. I discussed it with the executive management team at the time. We decided, is there anything that we're not doing to try and improve further, alongside the facts of the matter that there's more and more patients attending the hospital for treatment. So the best thing was to get an external review, and then we decided to expand it to include the Community Health Organisation. We asked them to review our resources and our processes, and then to look at any constraints that we may have missed. And the overarching objectives of that was, of course, to define and describe sources of flow challenge experienced within the ED and UHL, and determine and comment also on possible opportunities to enhance the existing patient flow approach, and also then look at effectiveness and the impact of flow initiatives introduced to date by UHL. So lots of words there, challenges, effectiveness, opportunities, so you can imagine what we needed to do. So Deloitte looked at pre-admission initially, and just the recommendations at the pre-admission level. Of course, they did ask us to review the AMU, ASU referral pathway and ED pathways, and to have them conducted to align with national guidance. Of course, the guidance changed 3 years now, 2.5 years ago with COVID-19, that we had COVID and non-COVID pathways. You're all familiar with them. They've been reversed since last Monday. I don't know if you're aware of that. So the COVID pathway through ED is no longer in place, other than the tracing that we have to do. And the AMU and ASU are being reopened as what they should have been pre-COVID, which is your medical assessment and your acute surgical assessment unit. So it's early days. That has to be embedded in, make sure that it works properly, and then direct GP access will be opened up in the coming weeks, and that will take some of the pain out of the number of footfall that go through the emergency department. It also suggested that our ED, MAU and SEU staffing needed to be increased to deal with the demand, particularly consultants and NCHDs. So as I've said, we've been funded for the NCHDs, and we've also been funded for 2 additional emergency medicine consultants, and the interviews are underway in the coming week actually, so that we get more on the floor senior decision making in the emergency department. We are looking at the SEU staffing at the moment. It has been an area that needs further input that we are looking at. ED avoidance measures. You all know if a patient comes into ED, inevitably they'll be admitted, so it's how we avoid them ever coming to the ED in the first place. And that includes consultant assisted triage in ED. The nurses do a really super job down there, but to turn it over faster, we do need more consultant assisted triage down there, and that work is in progress. Then for our NCHDs to document actually what are the ED avoidance pathways, so they're aware of them, because that cohort of staff turn over every 6 months, and to make sure that they know what our policies are. And then opening up access, as I said, to the AMU in particular for GPs, and any GP will tell you they've no direct access anymore and they find it difficult, but equally OPD access, so the port of call to ED then wouldn't just be there. I suppose the graph on the side is the one to look at. It's not the nicest, I suppose, in the sense that we're estimating that 3,000 further attendances will attend our emergency department this year. That's 4% growth. So last year was just over 76,500. This year predicting over 79,500 people to attend ED. So we have the busiest emergency department in the country as we stand. They also looked at post-admission, just the recommendations around patient flow at post-admission. They are really advising us that we need to go back to cohorting wards. I should advise that when Deloitte came in, they did over 25 stakeholder consultations. So these recommendations are coming from the staff, and we've taken it very seriously. So the cohorting, we had a plan around cohorting. We had to stop it all with COVID-19 because COVID became king, and isolating those patients was the priority. But now we have to go back to that. And there's good examples of great cohorting. For example, orthopedics, trauma, the specialist nurses are there, the specialist teams. It reduces safari rounds. It takes pressure off the ward manager in the sense that there's not 18 consultants coming to do a ward round at 10 a.m. So we are really trying to move in that area. But the main thing about cohorting is it does reduce mortality rates. It's really important for patients. So we are going to go at that this year really with a renewed focus. And also to ensure if we reduce safari rounds, then that there actually would be more time for ward managers to be part of the round and the MDT, because I know it's impossible if you have a lot of people at the same time. Criteria-led discharge, I would ask you to get an impetus on that. and get behind it, especially with your consultants that do visit you. You're the people that have the best relationship with the multidisciplinary team. But really, criteria-led discharge will allow us to discharge more patients at weekends. Particularly, it works in orthopaedics as well, as Professor Lennon would tell you, because they set out if you've no temperature, no infection in the wound, you can go home tomorrow. And it's easily done, but we have to do more of that across especially the medical fields. And I know it requires it to be documented at consultant level, so we'll be working with the clinical director on that. One thing that was very stark in the report is that we have the lowest base of health and social care professionals in our hospital group. When I arrived here 8 years ago, it was beyond low. It was very poor. And we've worked tirelessly with all our new bills to make sure that we put in a health and social care professionals. But not all wards have health and social care professionals. Some wards do. But you do need OT, speech and language, more physio, and social work is an area that's at a low base. So we have pitched for funding through the estimates for more health and social care professionals to assist patients at ward level. Delayed transfers of care then would be community-based work. How do we ensure patients that are stuck in the system who should be placed for outside of the hospital group happens, and there's a renewed focus on that. We have, I'm sure you're all familiar with the Tuesdays, but the COO will tell you about it, just looking at our patients over a period of time and making sure that they get access to rehab, etc. And then the most important thing for me as the CEO around bed capacity, and we're well versed on the fact that we have very low bed capacity in the Midwest region. In fact, we have the lowest bed capacity in an acute Model 4 hospital in the country, and we have the highest ED attendances, so it's easy maths. But this report tells us that we need 302 additional inpatient beds and 63 additional day case beds by the year 2036, just to stand still. Today, just to stand still, we need an additional 87 beds. You as frontline staff will tell me to know that, because if you count the numbers in ED and patients waiting to come in for surgery, it hits that figure every day. So we are doing an options appraisal now to identify the appropriate solution for that. And within that would be additional beds here, but also you'll hear us in the media talking all the time about an elective hospital. And it is our view the Midwest needs an elective hospital so that surgical work for subacute care can be done outside of this hospital, because we tend to cancel. It's the first thing we do when we have large medical admissions. The new buzzword is surgical hub, so we'll change that from an elective hospital to a surgical hub in the region for subacute care. And there's lots of options on the table that we can do, and that we're pitching government for at every opportunity to stand up and listen to us. And we've also pitched this report to all the politicians in the region to do the same, to actually help us with the case for the people of the Midwest. So that's really important to us, and it's stark in its own right as well, I suppose, to say that we need that many beds just to get through to 2036. Remember, some of us will be old and need those beds by 2036 too. The integrated community and hospital services then recommendations is the enhanced community care programme. Are you familiar with that? You probably are, but you just haven't heard the title. Around chronic disease management. You'd have lost some of your colleagues to work in the community at CNS level, and we're working with the Community Health Organisation on enhanced community care, where a lot of the government funding has been poured into the community health organisations in recent years to develop networks and to develop hubs. So if your elderly parent needs care, what do they do today? They come to the ED. Whereas in the future they will go to an assessment hub, they'll be assessed, they'll have their diagnostics, they'll have a team of health and social care professionals guiding them, and hopefully they'll go home. So they won't need emergency departments only if they're acutely ill. So that is the future, but it's a long way off, as you can imagine. But it's something that we're trying to progress. If you look at the Canterbury model in New Zealand, you'll see what they've done around enhanced community care. We have work to do. Those of you that work in ED will see that the primary care service is really floundering. The GP service, it's not their fault. There's a lot of retirements in the Midwest, so a lot of GPs are closing up services. A lot of Ukrainians are coming into the country saying they can't get a GP. A lot of people are moving to the Midwest who can't get a GP either. So when they ring for an appointment, it could be 3 to 6 weeks out. So what would you do? You'd come to ED, wouldn't you? Because the front door is open in ED. So we're seeing a lot of patients coming in, and the COO will talk about that as well in a few minutes. And then the community services, their existing funding around their beds, rehab beds in particular, and they have had some investment with new beds. We have to make sure we maximise them and use them. So a lot of work going on there. This you'll all agree with, and in the recommendations around e-health systems. I think as long as I'm here, everybody said we need an electronic patient record, and we do, just to follow the patient through the system across the hospital group and out into the community. And now more so than ever as we move into regional health areas, which is the new future, which we'll talk to you about on our next roadshow, because it'll be evolving as a design. I've just joined the national design team for regional health areas, so I'll be able to inform you really well on what the plans are. But the Midwest, of course, is coterminous. We're a natural fit with the community, and we may be one of the first regional health areas, but we'll see where that goes. And I'll be able to explain more to you what that means for yourselves. And then, of course, order comms is a very big thing for us that we've been trying to get. It's something that would make life very easy for staff across the system at laboratory level and indeed at ward level for results. And then our ICT infrastructure, there has been some upgrades after the cyber attack, but there's an awful lot more that needs to be done to assist people to do their job. And then leadership and governance is the other area that recommendations were laid out by the Delight team again. So additional operational responsibilities. So a head of operation services was recommended. So on this site we've an unusual model in the country in the sense that we have the directorate model. You're all familiar with that. They run the 6 hospital groups across the Midwest. But the view of both the Delight team and of HICWA when they did the review of the emergency department is that there should be possibly one point of contact at the hospital group that's dealing with unscheduled care. So we have interviewed and panelled for a head of operational services, and that'll be working very soon. We have William, who's done a sterling job, double jobbing actually as the interim operational head of services, and some of you will be involved in the DOSH, isn't it? Yeah. Another area that we have to work through is the clinical directors, just to assist them more with their role, because their role is quasi in the sense that they do clinical work with yourselves, but then they're managing with me and my team. So we have to give them more support to be able to do that job from a management perspective and formalise it more so that people are aware the clinical director reports to the CCD is the person who's actually in charge of the development of services in the region. We need to clarify more on directorate reporting and escalation requirements. What came back was that some people aren't quite sure what the directorate model is. Where does it sit? How do you get decisions made? So we need to tell you that story more, and we do a focus programme on that with you. A targeted programme on staff engagement, which the Director of HR will talk about in a moment. Quality and patient safety is our bread and butter, the care of patients, quality improvement. We need to fund that and actually grow it more so that at ward level and indeed at service level that there will be more quality patient safety roles to enable quality improvement rather than all the time dealing with complaints and risk, that we'd actually be dealing with innovation and improvement. And then finally, development of a transformation office. So a lot of you will hear about the PMO, which is the Project Management Office, and that the secret's in the title that they manage projects, and it's the Prince style management projects. But for us, it's a transformation office that I'm interested in developing. So some of you may be interested in that. And what I'm looking at is innovation, ideas for development in the region that come from staff who work in the service, transforming strategy into actual real work on the front line. It'll be a team of people working directly with the Chief Strategy Officer, which is Suzanne Dunn, and reporting into me. And there'll be lots of innovative, unusual, interesting work in the Transformation Office if people are interested in innovation, change, development, change management, etc. So keep an eye out for that, because I'm starting to do the job specs on it. So next steps, every year it's the same thing. We have to improve patient flow. We have to work together as teams as to how we do that against the constant number of patients coming into the hospital. You'll see the sod was turned for the 96-bed block. It has, it's great to see builders back on site again in one sense, and in the other it's difficult for staff because parking spaces get eliminated very quickly, and it's difficult for us because we have to plot the development of the site and make sure we deliver it on time in the next 2 years. But it is 96 single room block, just like the other single room blocks we have, and we'll be sitting down to work out what will they be. And I'm sure our IPC people will be delighted to have single room facilities, yeah, again. And of course we'll continue to bid for extra resources in the estimate process and the National Service Plan. We've been very lucky with a lot of things around resources. Because we've been building, we've been able to increase our staff, and you'll hear about that very shortly. And then the winter plan, which I've described, we need to implement that pretty quickly, because it's November really, isn't it? So we're in winter, but winter usually runs until March anyway. So we have some work to do. I'm going to hand over to Noreen Spillane, Chief Operations Officer. She's going to talk to you, as described by Elaine, just on the patient flow on scheduled care, and I'll take questions after.
Okay, thank you very much. So the first slide there is just a map or an outline, I suppose, of our activity.
Sorry, Noreen.
Oh, sorry.
Yeah,
Here,
just so the people
can wander around. Okay. Sorry, apologies. Okay, so that just shows you, I suppose, our activity on the site at a point in time there when we had the Deloitte, when they came in to do their report. And as the CEO already said, we anticipate 79,500 attendances in our ED by year end, which is a huge increase again. And we've also seen a 6% reduction in our GP referrals to the emergency department, but we're still seeing our high numbers coming through. And as CEO said, there's lots of issues in the community around, GPs retiring and people not being able to get their GPs appointments on time. It talks also there about outpatients, which I'll come to in a minute, and also our integration with our hospital and our community colleagues. So their bed occupancy is at 85% in their community nursing units, and we really do need to try and maximise the our transfers and utilisation of those beds. A lot of them, I suppose, are just in terms of their infrastructure isn't great. A lot of them are very old buildings. I know there's plans for new builds on a few sites, so they're grappling with that all the time, especially from an infection prevention and control point of view, because they don't have single rooms and they have multi-occupancy areas. So when we're transferring patients, we have to be mindful of that. So I'm not going to go through everything. 105% occupancy, we definitely know what that feels like on the UHL site. And this is the other thing, is just around our discharges before 11 o'clock. There's only 6% of our discharges before 11 o'clock, and that's something that we're continuously working on in terms of trying to improve that. So the 5 fundamentals of unscheduled care. When Deloitte came in to do their report, the CEO just went through all of the different headings there. So they did, I suppose they wrote their report under those headings as well. And when the PMIU team and the HSE support team came down to us in July, they spent a couple of days with us in June, and then they came down for the month of July. They also worked under those different headings: so leadership, culture and governance, patient flow at pre-admission, patient flow at post-admission, integrated community and hospital services, and using information to measure and monitor performance improvement. So with that in mind, then they left us with some follow-on actions, and we worked very collaboratively with them when they were here. The CEO has mentioned about leadership and governance and the new head of service in place, and also we have an unscheduled care meeting every 2 weeks, and we're going to bring that back now to weekly, and that will report into a joint governance committee between the community and the chief officer and the CEO. Around education, I suppose there's a lot of education going on at the moment around red to green. Many of those in the wards will be very familiar with it, but it's really about trying to increase our knowledge around that for every member of staff, so that we can use it as a tool every day, and the patient flow team then can see that, how many patients have planned dates of discharge, how many patients are going to be transferred to Ennis and Nina, and all of that. So it helps us to work each ward as a dashboard now, so that everybody can see it and work together trying to enhance our patient flow. Engagement is about engaging with all of the staff, and also in terms of the community and our engagement with the community, to ensure that when their acute episode is finished, that they, in a timely fashion, get back into their homes or out into the community, into a more suitable, for home. Enhanced admission avoidance, the CEO mentioned that already, and we've done a lot of work on egress pathways, even from our Model 4s to our Model 2s. There's been a workshop, many of you were involved in that, about trying to maybe streamline that process. They've been in place for a long time now, and it's really trying to see whether we can cut out some of the steps. We're also looking at pathways then from Model 4s and Model 2s into the community, into the rehab. We often have issues around that and trying to get our patients across to rehab, in terms of getting patients assessed and on that pathway. Integration, we've discussed, we already have an enhanced community care, as the CEO referred to, where there's lots of initiatives, and we co-chair, a lot of our staff in the hospital side actually co-chair a lot of the committees with the community. So it's really to try and increase and improve those pathways like ICPOP, the older persons pathway, the chronic disease hubs, etc. The medical rota redesign and workload management, that's specific to here in UHL, and Dr. Mike O'Connor, the National Clinical Advisor to the Acute Services, is working with Dr. Gareth Quinn, who's the Clinical Director for Medicine, and Fiona Stee, the General Manager, around looking at the medical rota on this site, because a lot of consultants end up with very high numbers after take, and I think just from a workload management point of view, we've also had a lot of new consultants in place as well, and it's really just to make sure that the workload is spread across everybody. Cohorting, the CEO mentioned already, and that I suppose is linked a little bit to the medical rota redesign. So once that's completed, we'll be able to finish our cohorting, but we're working on it anyway. Then over 75s, it was mentioned also about our older persons assessment unit, or geriatric assessment unit for patients, and that just opened last week, and with the enhanced allied health professionals. And that's a work in progress, and we'll see how that goes. But I think it'll be a better experience for the patients, and it's really a unit, for assessment to discharge rather than assessment to admit, if possible. I think it's very difficult when patients come into hospital. If they don't need to be in hospital, it's much harder to get them back into their own environment again. Long Stay Tuesday then is where every patient on all of the sites now, we started on the UHL site, where we looked at patients over 14 days. So there's teams go up to all of the wards, and multidisciplinary teams, and the community staff come in also, and they just review every patient to see, in terms of red to green, which you'll be familiar with on the wards, just to see where there are blockages for the patient in the patient's pathway, where we need to intervene and maybe try and look at it in a different way or whatever. We've reduced those numbers of patients down from, there were 138 in early July, and they're down to 118 now. Still too many. We did get down to 80 there a couple of weeks ago, and actually I think they're looking now at over 10 days, just to see whether or not we can move the patients on as soon as their acute episode is complete. And it's also reduced the average length of stay. We started at a very high 38 or 39, I think it was, and then it's down to about 34 now, and the median length of stay is also reduced from 24 to 21. So that's really just with a focus on that particular cohort of patients. And then our waiting list is the other thing. We have 51 patients on our OPD waiting list. In fact, that's come down now to under 50,000. It's about 49,500, which is really good. We started at the beginning of the year at 58,000. We have just over 4,000 on our inpatient and day case waiting list, and just about 200 of those patients are over 12 months. And then we have nearly 2,000 patients on our GI scope list, which sounds like a lot, and it's still too many patients on waiting lists, but there's been a huge amount of work done this year with John Doyle and his team, and I know many of you have been involved in it as well, with extra clinics. We've also outsourced, we've used every source of funding we can possibly utilise to get patients seen in a timely manner. We're also trying to build capacity in-house so that patients don't have to travel outside of the region. We have a very low private healthcare access here in the Midwest region, so many patients do have to travel out, and we're trying to build capacity within to prevent that. So in terms of our targets, we've 29% of our outpatients are reaching the 18-month target. We're hoping to get back to 36 months, still way too long. In some specialties we'll do better, and in some we won't make the 36, but that's our target. Our inpatient day case will definitely get to 12 months by the year end, and our GI scope list, we've only 2% reaching the 12-month target. So you can just see there where we started, and we've actually come down lower than that now, and 14,000, nearly 15,000 patients are waiting over 18 months. And there are, see our score, and it just says there about the 228, that's down under 200 now as well. Our patients waiting 12 months. So I'll hand over to Lorraine Rafter, Director of HR. And we'll
Okay. Okay, so good afternoon, everybody. Lorraine Rafter is my name, and I'm the Director of HR. So you're all very welcome here this afternoon. There's just four, I suppose, areas that I just wanted to update you all on today. And they are the reversal of the Haddington Road hours, NISRIP, and our revised dignity at work policy, and then staff engagement. So if I just start off with the Haddington Road agreement, you're probably all familiar that back in the day in 2013, when the government was in trouble in terms of funding and resources and everything, in terms of the financial difficulties that the country was in, there was a requirement for the public service to, I suppose, look at its efficiency. So there was a move to increase the working hours of all of the staff that worked across the public sector. So, but part of that agreement was a decision under the Building Momentum Agreement that there would be a reversal of those hours. So you can see here, I've plotted on the graph, the nursing and midwifery cohort of staff, their hours now have reduced down to 1.5, management admin down by 2 hours, health and social care professionals down by 2 hours, and then medical and the NCHDs and consultants down by 2 hours. So I suppose that in itself is fantastic, that everybody's got reduced working hours, and you will have seen that reflected in your pay slips back in the 1st of July when it came in. And so basically there was no, I suppose, reduction in people's basic pay, but what you would see is that your hourly rate of pay went up. And I suppose that's fantastic in terms of people's work-life balance, and that I suppose it has left challenges within the workforce in terms of filling those gaps with rosters and that. So we've been doing a piece of work, I suppose, ourselves in the background and on the Haddington Road hours and looking at the gaps in the services. So especially for our frontline staff. So we're looking to replace those hours with direct replacement. So we've been putting a bid in because every government department will be doing likewise across the country. So we've put our bid in, and I suppose there will be about a sum of 355 million that will be available across the public sector for this Haddington Road agreement to be fully implemented. So I suppose we hopefully will have some update on that towards the end of this year. And I suppose just in relation to what I was mentioning there, your pay slips and that, can I just have a show of hands in terms of NISRIP? Are you all familiar with NISRIP and have you registered on it? Not wanting to name and shame. But that's good. It's very encouraging to see. And I suppose I'm encouraged to know that 92% of our line managers have registered on it. So NISRIP is the National Integrated Staff Records and Payroll System. And this is an electronic platform. So from now on in, we're mandating that we will have this as, I suppose, the go-to for you viewing your pay slip. So instead of getting your pay slip in the post, to be able to look at it online. And I suppose we have 52% of our staff that are registered. So we're hoping that obviously that will increase towards the end of the year. So we realise that not all of our staff are office based. So I think that's where we see some of the problems laying in terms of getting that additional. We're hovering around the 52%. The NISRIP team have been out at the various different hospital sites trying to, I suppose, encourage people, and where people are having some difficulties with registering onto the system, that's the opportunity. So I know that they were out there for 4 days in Croom, they've been to Ennis, they're on their way to UHL towards the end of November. So again, just to encourage staff to, when they see the stand, if you are having problems with registering, to make contact. I suppose in itself, what when I've been speaking to the team, so Roseanne Buchan is our NISRIP lead. And I suppose one of the things that Roseanne would have said is that now that basically people have been engaging, that there is a whole lot of queries that people have, and that's fine, and we're able to deal with those, I suppose. So just to bear with us, but again, just to encourage everybody to to engage with the system. And just in relation to the Haddington Road as well, there was a whole load of background work that had to be done on the SAP system, so in terms of devisers and that. So Kathleen McHugh, who would have previously worked in recruitment, has been seconded over there to work with Roseanne in relation to the Haddington Road errors and all the background changes that have to be made on the system. So that's NISRIP, and as I said, hopefully towards the end of the year I'll be seeing that moving up into closer to 90% compliance, and we'd be very happy with that. Then just another, I suppose, update from ourselves in relation to policies that have come down nationally, and one that I suppose came down was at the end of August was the revised, updated dignity of work policy. So we always had a dignity at work policy within the HSE, but I suppose this has been updated and refreshed. And I suppose it's been updated and refreshed, I suppose, in light of, I suppose, a lot of case law that's built up over time and understanding more about bullying and harassment in the workplace. And I suppose there's different stages now put in within the dignity at work policy framework. And one of the things that I suppose has been, it's well recognised that mediation is a really useful tool to use when you have interpersonal difficulties in the workplace. So we ourselves within the HR department had a Teams meeting with the National Mediation Service. So we'll be looking to get them to come down and speak to us as well about what services they can offer. But really what we're trying to, I suppose, impress upon is that when you have mediation early on in the process, it can often resolve the issues. If you get mediation, I suppose, involved later on, it's more difficult, things get more entrenched. And I suppose one of the things within the new policy framework is that there's a new secondary informal process, and it involves a nominated person. So we don't have anybody trained up at present as in that role as nominated person, but I understand nationally there is. And so we would be, when we have those lists of people, and there, I suppose there is a support between the complainant and the respondent. There's also training available on HSE land, and again to encourage yourselves and all of your staff to access that as well. And I suppose one of the things within the dignity of work policy and the framework now is a new requirement to monitor incidents. So, you'll see at the back of the actual policy, there's a new framework in terms of, a template that you are required to complete. And I think for us in HR, it's very good because it helps us to identify and track and trace and identify patterns. And I suppose those patterns are something then that we probably need to do something about from an organisational point of view then in terms of, intervention strategies. And I suppose that brings me on to, what some of the stuff that we have been doing in terms of staff engagement. And we had a staff survey that was carried out nationally. It was commissioned by the National Director of HR, and all the hospital groups around the country were mandated to, I suppose, complete it. And ourselves here within the UL Hospitals group, we probably one of the highest uptake of the survey, which was really, really encouraging to know. But I suppose some of the things that it did highlight to us, and we would have shared those results with you at the staff webinar back in March of this year, but some of the things that it did identify, and we broke them down into themes and particular priorities for ourselves, was things around diversity, equality and inclusion within the workplace, health and well-being, and we're doing a lot in that space. We have the Staff Health and Wellbeing Centre here in the UHL site, and I know that that's been a huge success. Other issues around decision making and how decisions are made in the workplace, and our communications with our staff as well, and promotional opportunities, people saying, things like SBCs and issues around that, and people feeling unsure about their permanency and all of that. So we're going to take on board all of those issues. Another really topical area, and when you look at the makeup of our workforce, was menopause, and that's very topical at the minute in the media. So if you look at our workforce, there's 80% female. So again, and our age cohort are within the 50 plus. So this is something that, again, was a very prevalent theme for us. So it's something that we are going to engage. So we've got our staff engagement steering group has been set up, so I chair that, and I've got members of my executive management team sitting on that as well. And the intention is that we would have staff working groups on each of the sites then. And again, it's a positive working group, so we know what the issues are, so it's, I suppose, our job now to define some plans around improvement plans to address those issues. And I think that for us is really important, because we know that, we made reference to the fact that we've probably recruited an excessive amount of staff in the last 18 months in terms of our numbers, almost 1,000 new staff, which is absolutely fantastic for our group, but it also brings its own complexities in terms of managing that staff. And as we move into the space of where it's a very tight labour market in terms of us recruiting and retaining our staff, we know that this is really important to us in terms of that and staff engagement piece. So again, to encourage people to look out for the working groups, and if you have ideas and suggestions, absolutely love to hear from you. So that's it, I suppose, in terms of my 4 slides that I wanted to talk to you today on. And I think we're now going to open it up to the floor for all of us for questions and answers. Is that right?
Yeah.